Good afternoon, good morning, good Monday, good Sunday, whatever day it happens to be for you. I'm Mary Jo Murphy, and this is our 7th patient seminar, Wiping Away Shame, Rethinking Old Advice. Our participants, or our speakers today, are Dr. Richard Turner. He's a professor of surgery at the University of Tasmania and a specialist in general and digestive health. He has been practicing HRA and treating anal lesions since 2003. Dr. Messick is an associate professor at the Department of Colon and Rectal Surgery Division of Surgical Oncology at the University of Texas MD Anderson in Houston. And Dr. Jenny McCloskey, who's going to be helping us with our questions and discussion afterwards, is a sexual health physician at Royal Perth Hospital, where she's responsible for researching and treating HPV. And over the years, she's become an expert in sexual health. She has a lot of insights into what this disease means to people in terms of our topic, shame. Okay, Audra? Each one of these seminars is in honor of someone, and this one is in memory of Stephanie Zimmerman, August 22nd, 1989 to August 7th, 2023. Okay. Craig, if you'd like to start.
Thank you, Mary Jo, and for IANS for letting us put this on for the benefit of our participants today and future patients. We hope they'll never experience this. I'm going to share my screen, and then I'm going to begin with a brief background. And I think to avoid my own distraction, I'm going to stop real quick, and I was going to try to hide myself, but that's okay. Let me start off with this being a talk I have given before at a variety of different places and different conferences, including our American Society of Colon Rectal Surgeons and different global surgical oncology summits. This is an extraordinarily interesting and passionate part of my career. So if I say something, please write down a question and be sure to ask it in the chat. I'll try to keep this as non-basic science as possible, but it will include some that's very important. So this is called the anal HPV-related disease, who's really at risk, brief discussion. The next thing to importantly know is I have nothing to disclose. None of this is anything other than just general information that you can find on the internet or in books. HPV. This is what I call the fun facts part of the talk. This tells us a lot about the history of HPV. It's reportedly hundreds of millions of years old, that it exists across multiple different mammalian and reptilian lineages. It's not just in humans, but it's in primates, other animals, as well as other birds and turtles, and has been reportedly back many other different types of species, including birds, as you see here. The interesting part is that there are roughly 200 or so human strains. It seems like every 2 or 3 years we find they've found another 50 to 100. And of those, 40 of them have a strong predilection towards the anus. There are different types of HPV. It's not just a one-size-fits-all virus. And we can see that in this part of the slide, the alpha strain is or genre is the most important one, and it is truly the type of HPV that is associated with the cancers of the GU, as well as anal rectal and oropharynx sites. The other ones that you see here, I find this to be interesting during my research, is understanding that the mu genre is actually associated with the plantar and palmar warts. Those carry no cancer risk, but if you've ever known someone who's potentially ever had plantar warts, it's just made me think today perhaps that's someone who may be potentially at risk for not clearing HPV after exposure. But that's just me on a side note. What's so special about this virus is what fascinates me the most about it. It is extraordinarily small. It's a virus, so certainly it's small, but this thing's really small. It's only 8,000 base pairs. It's a circular kind of strand of DNA, and it's shaped so tightly and densely packed that it fits into this really small ball that you see here. It is able to evade a lot of different immune systems, including ours, which is very hard to do, but certainly has proven to be able to. It's important to know that from the science standpoint, it's got a capsid and it's a non-enveloped virus. That has something to do with its ability to withstand life and exposure to all the things that we use to clean it, and air and sunlight. It just doesn't get damaged by those things, which makes it thus a very transmissible virus. It is extraordinarily simple in its the genetic code. It only codes for 8 or 9 proteins. And as you can see here, the different ones that you see are all based on the different L protein, which again is basic science and not necessary, but just one little gene changes its entire potential for what it can do in life. We see here plantar warts are caused by those types of HPV. The other warts we see 6 and 11 commonly for anogenital warts are 6 and 11, and then the others that we see there, specifically those listed in red, are the ones we worry the most about that are associated with and can cause cancer. The transmissibility and epidemiology of HPV has been very interesting. My population of patients that I've managed has been something that has been becoming more recognized across the country and in the world. As Dr. McCloskey also has managed these patients too, but is sort of a group of patients which is not considered to be an at-risk or a high-risk group. So when I see them in the office, I had to understand a little bit more about why they're having anal HPV. If they're not defined as a high-risk group, HIV positive patients, those engaged with men having sex with men activity, or transplant recipients, which we do have at MD Anderson. But that outside of that group, there's really not a whole lot of data on them. But yet, that's the face of the anal squamous cell cancer population. A 63-year-old Caucasian female fits that bill completely and otherwise wouldn't get screened. So I had to look into it and understand a little bit more about it. And so here we go. There are some transmission falsehoods and stigma, and then there are some undisputed truths that I want to just lay out here right now because it's very important. We all understand about HPV and what it's associated with. This is what people historically think in the general public, and surprisingly and unfortunately in most physicians' offices. You only get it if you engage in anal receptive intercourse. You only get it if you're HIV positive or if you live with AIDS, if you only have unprotected sex. It doesn't really cause symptoms until you have lesions. And if you don't have symptoms, therefore you don't have an infection. One of the biggest fallacies I suspect is probably out there. Don't worry about it if it's not a high-risk type. And that if you had it, you can clear it and then you're free from it. And of course, the biggest one is that it's not going to happen to me. The undisputed truth, however, that it is the most common sexually transmitted infection. It is also most commonly transmitted via sexual activity. But all we have understood from late is that it really only requires direct contact with a virus to exchange it from one person to the next, which thus does not maintain the attitude of it's only about sex. It's in fact a lot more than just sex. In my understanding, I tried to understand like how else you can get it if it's not via sex, and there are 3 ways that you can get it. Though not most common, it is important to understand that there is a potential vertical transmission risk, and that is that the first reported case of infantile respiratory papillomatosis was in 1956 and related to HPV. In the 2012 studies, both the Korean and the Finland study, they looked at family transmissibilities in infants at 1, 3, and 7 days after transmission and up to 2 weeks, and found a very high concordance rate with moms. And then the Canadian Heritage study in 2016 also complemented that data. The truth is, and that doesn't mean to scare anyone, that you've maybe potentially passed it on if you're a woman in the group. The thing is, we get it through a variety of different reasons other than just sex, and that's what I'm trying to show here. There is most likely a very high indirect transmission for HPV, and that is shown by Dr. Roden and the group out of the NCI, National Cancer Institute, in 1997, that showed that HPV itself as the virus live in its own, like in the general world, is very resistant to drying out and dying. They tested it again up to 7 days on different inanimate objects with different types of cleaning agents and treating agents, and they found a variety of very different ways that it is killed. But at room temperature, at 7 days of the study, they found that approximately a third of it was still alive. I found that to be fascinating. This is the only way to kill it, but we can't autoclave each other, so that's not going to happen. And the half-life is roughly about 3 days in the open atmosphere. So it's very alive and very common. The real question is, what about if it's not direct transmission with the virus, can you pick it up two different ways? And the idea here is that we slough off about 40,000 squamous cells from our body every single minute, not hour, not day, but every minute. And the important part here is that the anus turns over every 4 days. So there's a brand new anus, essentially, you get every 4 days. That's a ton of squamous cells that are shed. And if there's any HPV that's in them, then you just have a time capsule that HPV can survive in pretty much indefinitely until it's picked up through standard fecal oral transmission, which is like how we get all our viruses from our kids. And then it just kind of goes where it needs to go. So the reality check is that it's everywhere. You can get it through indirect contact with squamous cells that may harbor HPV in it. It is transmitted also vertically probably through just birthing canal and just general exposure. It is also with direct contact with the live virus. So that being said, I'm fairly certain that everyone on the planet has been exposed at some point. And though this is not designed to be something that's shocking to everyone, the truth is it should make you be at rest because we've all been exposed and you're not likely exposing anyone else to it. It just is the way that it is. So from that, I will end with my introduction of sort of a background of HPV, and I can let Dr. Turner get started.
Thanks very much, Craig. That was a great summary. I'm going to try and share my screen now. Hopefully people can see that. So I'm just going to share a little journey we had several years ago when we did a study of women with anal abnormalities, HPV-related anal abnormalities. When I think about it, this actually did bring me personally to be aware of the stigma and shame associated with this condition just by doing this study. First of all, just a little bit about where I'm coming from. I work and live in Tasmania, which is a small state of Australia, which is at the very bottom end of Australia. It's a fairly small population. It's about 600,000 people in the whole state. It is the traditional land of the Palawa people, who called it Lutruwita. And there are two major centres that I do HRA clinics in. One is in Hobart or Nibbaluna. That is the capital city. It's a very lovely place that it's probably the only capital city in Australia where you can actually see snow in wintertime. So it's a very nice place to live. Launceston is about 2.5 hours drive north of Hobart. It is also a moderately large provincial city with a referral hospital. And so this is where we actually did our TASGAN study, which was the Tasmanian Gynecological and Anal Neoplasia study. What were our motivations for doing this? Well, I think, as Craig said, a lot of the people I was referred and screening were actually people that didn't have the traditional risk factors for anal cancer. And we know from global studies that generally the typical profile of the anal cancer patient is a woman in their early 60s who are heterosexual, don't have HIV or any other risk factors. I think following on from what Craig said, this virus usually gets into the basement layers of squamous epithelium via microabrasions. So I think we can fairly imagine how that happens in men who have sex with men with receptive anal intercourse. It's less obvious in women, although we could probably assume that it's a proximity thing. So if you're infected, in the front, in the vagina or cervix, it's not very far to actually auto-infect into the perianus and the anus. We also know that, just from general surveys in the Australian population, at least, only 1 in 6 women have ever experienced receptive anal intercourse. So we really embarked on a study to try and find out what was it what was the co-carriage of women who'd been exposed to HPV through gynecological neoplasia. So just a little bit more about background about Tasmania in particular. So we got a little bit of funding from the local cancer council, and to make our case, we looked at previous cancer admissions over about a 40-year period in the state. It's a rare disease compared to cervical cancer, obviously, but we can see that the rate was increasing over that period. Maybe that was from better documentation and better case definition, but still, I think it's a significant increase in the incidence. And we can see from the graph there also that, once again, women tend to predominate over men. When we looked at our case series, we did a record review. Only 2 out of the 130 or so women or people were HIV positive. That's kind of interesting. I just wonder if some may have been, but we didn't actually measure it 3 decades ago. And also relatively few people with a previous history of other HPV-related conditions. Once again, it may have been a retrospective issue with the data. So for our TASGAN study, we basically decided to go for a population that we know had been exposed to high-risk HPV at other sites. So we wanted to determine the co-prevalence of anal cancer precursor lesions, and also explore what the determinants of those things might be in women who had had a previous history of HPV-related genital dysplasia or cancer presenting to the clinics at our hospitals. So most of these were actually going to be cervical lesions, but there were also a small number of vaginal and vulvar dysplastic or neoplastic lesions. Basically, we used cytology to screen for the abnormalities, and we also did co-testing for high-risk HPV. Anyone who achieved cytology greater than low-grade squamous intraepithelial lesion was referred as part of a care path for high-resolution anoscopy at one of the clinics that I do. So we had a questionnaire which we asked about demographics, medications, tobacco and alcohol use. And as a novel thing, we decided, based on the hypothesis that we'd brainstormed, we asked the women how they actually attend to their perineal hygiene. So how do they wipe themselves after urinating or passing a bowel motion? We then looked at the medical records of these patients and got a full gynecological HPV-related history, obstetric history, and any other relevant past or current comorbidities, particularly gastrointestinal things like inflammatory bowel disease and any other perianal conditions like fissures or fistulas, etc. And we analysed it with log binomial or multinomial logistic regression. So what happened? We're a small population, but we approached 318 women. Just over half of these consented to participate in the full study, and we had adequate cytological sampling from them. Although in 123 there was we had a sufficient volume for HPV typing. So we had an analysis cohort of 163. The median age of those women was 33 years. So this is a rather busy slide, but what we can see here is that if we look at the three sort of like metrics, I guess, anal cytology, histology of subsequent HRA guided biopsy, and anal HPV typing, we can see that still roughly about 1/3 of these women had some sort of HPV related abnormality, and 60%, or to 70% did not. So when we looked at the prevalence ratios of factors for those with anal abnormalities, what was interesting was that certainly age was a predictor, and that stands to reason. I think we know that as the longer the virus is in situ and has integrated itself into the DNA of those cells, it can mutate over time, and high-grade lesions can manifest. The other one was inflammatory bowel disease. Now, maybe Craig's got some better ideas about this. I haven't really looked into it, but I could hypothesize that perhaps someone who has frequent diarrhea and so on may be wiping themselves more frequently. There may be more risk of abrasions and so on in that area, leading to autoinfection. Smoking, we know, is a risk factor for HPV-related abnormalities. But sort of the novel finding we had was that women were more at risk if they did the traditionally taught, I guess, front to back wiping, either post-urination or defecation. And it was somewhat protective for those women that actually said that they dabbed themselves rather than swiped, I suppose you would say. So that was kind of interesting, and it kind of like really confirmed our hypothesis that yes, you can get autoinfection simply by transmitting the virus from front to back. If you're infected with the HPV in the vagina or cervix area, when you are in a period of life when you are shedding virus, you can actually transmit it backwards into the perianus and anus. And I suspect also it's a function of how assiduously one wipes themselves as well to create microabrasions that cause the autoinfection. So basically, that's what we concluded. And I think in the end, really, did this really add to anything scientifically or clinically? Perhaps not. But what it did mean is that we could actually validate and with our counselling of patients, and I still do all this all the time with the women that I see in the clinics. If they're asking me about how they got it, etc., I can give them this information. So it's been quite useful in that respect. What did emerge though from the study was that it made me really aware of the stigma and the shame associated with this, because when we first planned the study, we were basically warned against asking in our questionnaire about receptive anal intercourse due to ethical concerns and sensitivities and offending sensibilities and so on. So we did not. In the end, we were conceded that we could actually maybe do a pilot study of about 10 or so women to see if they would be prepared to answer that question. In fact, they all did. By that time, we'd actually done the main questionnaire. So we did send out a second questionnaire to the women, but most of them had left the study at that stage and weren't really inclined to respond to us. So that was a limitation of the study. Having said that, it was published in a good journal, and we explained the reasons for that. And I think the the results that we had anyway spoke for themselves. But it did actually make me aware that, you know, some questions were a little bit off limits, sadly. The obstacle we had, and I suppose you called, in fact, it wasn't, it was kind of a good thing for me, really, because unlike another study from Australia that people might have heard about, the SPANK study, which was a really, really well-designed and fantastic study, which was more of a natural history study, although it did have actually a safety net, so it wasn't purely that. My gynecology oncology colleagues that were giving me these patients for the TASGAN study would not countenance me just following people up. So I really had an obligation to treat and continue following up the women that I found to have high-grade lesions as part of the TASGAN study. So that meant that I had to go to my public hospitals and say, you know, can I please have a dedicated clinic for this and a modicum of funding to do it. So in fact, that was kind of a good thing. I could actually wave that at them and say, you know, I need to set up a clinic. Thank you, that's ongoing. So interestingly, the threat that we had was my main co-author, Steve Simpson Jr., and I were called up to the director of the Research Institute to say that they were very concerned about some rather ribald comments about these two men doing a study about how women wipe their bottoms. And that was a little bit offensive. We got over it by the fact that we had very robust statistics, and we also had two women who were co-authors on the study, Penny Blomfield and Alyssa Cornell. I'd also like to acknowledge our statistical advisor, Lee Blizzard, who oversaw that, and Seppa Tabrizi, who did the HPV analyses. But and we got away with that. But once again, it sort of made me realise that there is a whole lot of stigma and things associated with this, which I think we need to disabuse ourselves of. So in the end, what can I conclude? Well, I suppose as a clinician, I think we need to probably communicate with confidence and compassion. And there's a number of things we can do. We can certainly provide an understanding to our patients about how HPV infection is acquired, and particularly with respect to the high-risk HPV variants, and the consequences of that. What are the risk factors? I think we should also normalise consensual sexual practices. So personally, I couldn't care less how people get the HPV, but it does help to, you know, maybe disabuse people of certain myths and so on about how it can be acquired. And I think we just need to be very non-judgmental and neutral in the way we ask these sort of questions. I don't know about Craig or Jenny. I usually don't ask people about their sexual practices unless they ask me, is something a risky behaviour, etc. And I think in the end, I can tell people that, you know, intimate contact is usually just a frenzy of all body parts. HPV is very infective and infectious, and you know, it's very easily acquired, even though it does have the label of a sexually transmitted disease. And finally, I think, and Jenny will probably elaborate more on this, but I think we need to, you know, be fairly attuned to the possibility that some of our patients might have experienced past trauma, and acknowledge that where appropriate. So thanks for listening. And I look forward to further discussion.
Jenny, would you like to add something? Oh, I think you're muted. We can't hear you.
Did you press mute on your phone too? Maybe if you're using your phone, it's doubly muted. Man, that happens to me so often. Well, I think while she was trying to get that sorted out, and interrupt me anytime, I put an answer to the questions you had, Dr. Turner, in the chat. And that is the only reason I would potentially ask someone about their sexual practices is so that I can get a sense of who's considered high risk and not to ensure that they get the standard of care which they need for HRAs in the high risk populations. Other than that, I agree with you. It is irrelevant how you get it. I mean, on so many levels, as I had alluded to in my introduction. It is, and I tell patients that I don't care what you do because I don't care. Although it most likely did come through one way or another, it doesn't matter to me anyway. It's there. So done. Let's move on. I hope I didn't scare anybody with my comments. I was meant more to be reassuring that that anyone who has it didn't do anything to get someone else at risk. I mean, it's just, that's the whole point, is it's part of our lives. So it's not to be shamed.
Farrah Fawcett's doctor called it invisible glitter, which
Yeah.
I think is a good way to look at HPV.
With the exception that it doesn't wow you in a good way.
Yes, yes. You know, while we're waiting for Jenny, one of the participants, one of the people listening who's a psychologist, said that that there may be a connection between shame and guilt around this with oh dear. I'm getting an echo.
Now you're muted.
I'm not sure why that just happened, but hopefully it won't happen again. About the fact that one of the basic psychological tasks for toddlers between 2 and 4 is toilet training, and it's revolves around working out shame and guilt to stop babies and toddlers from pooping everywhere and smearing feces and things like that. And I just thought it was a really interesting observation, you know, how this idea of shame and guilt around bowel movements or that part of your body may go back even further. So I just wanted to bring it up because I thought it was a fascinating comment by Dr. Loeb. Anyway, if you have questions and you want to put them in the chat, that would be wonderful. I hope that Dr. McCluskey comes back soon. One of the questions I always have, and it may not, what does smoking have to do with anything?
Yeah, it's a really good question. I tend to have an opinion that it is irrelevant in terms of transmissibility. I don't think, and Dr. Turner and McCloskey can correct me if they know any data, it's an associative risk factor that historically has been associated with maybe riskier behavior, but that's it. There's no defined link that says if you smoke, you're at greater risk. It doesn't do anything specifically to the immune system that I'm aware of that would put anyone at a predisposed risk. I've seen more patients without a smoking history than those who are with. Certainly, I find that the patients who are actively smoking may have a bit of a different phenotype or pathology of their pre-invasive disease, but that's only anecdotal, so I can't say anything to that degree that it's bad or it's good for patients either way. I think it's something that within the IANS community and within the American Society of Colorectal Surgeons, we're going to try to change that language in our update this year that says that smoking is not a risk factor.
Okay, can people hear me now?
We can't
No,
see
Jenny, if you could just yell really, really loud from Australia, though, that'd be fantastic.
Okay, well, I'm on the far other side of Australia compared to Richard. So, and Scotland and the UK fit into a small part of Western Australia. So we're ginormous with a very spread out population. But look, what I wanted to just say is thank you for both of you presenting. And I wanted to, particularly as a clinician, so I'm a sexual health physician, so people are really embarrassed to come to my service. And within 2 minutes of talking to people, they're telling me about the most intimate aspects of their lives. But there's incredible embarrassment with people, and particularly I find, because we run a diagnostic screening and treatment service for people with high-grade intraepithelial neoplasia, and people are, particularly women, but also some men, just mortified at coming to see me. They're embarrassed. The discussion's awkward, and all sorts of things come up in the discussion. And as a clinician, Richard's work to me has made my life 1,000% easier. So often people come, they know the disease in the anal canal, and in society, it's like they're accused of having anal sex, and it's a taboo subject for a lot of the heterosexual population. And so to have Richard's data, which means it's spread by skin contact, and in fact, whenever I present Richard's data to nurses, they all go and say, I'm going to spread the word, just as women, just dab, don't write white front to back, which is what our parents or our mothers all taught us. So it's incredibly profound information to make patients a little bit more comfortable to say, look, we're not accusing you of anal sex, we're just talking about the way this incredibly transmissible virus might have got there. And it's extraordinary. I've even found that we have a colonoscopist, a gastroenterologist at the moment, who is, when he does colonoscopies, they turn the camera around, and on the way out, they're actually starting to look at the anal canal in men and women. And they're actually finding warts in people who are as part of their colonoscopy, and that was all disease that was missed. So I think this infection in the anal canal is far more widespread. We need a lot more research, but also it needs to be diagnosed and treated. So there's a lot of research that needs to be done. But all I can say is, Richard, thank you for publishing that, because it's just means so much to my patients that I can say it's your wiping practices and not anything else. The other thing that, just talking a bit of scuttlebutt, I was recently at the colposcopy meeting, the Australia and New Zealand Colposcopy Society in Queenstown, and we had El Majora visiting he runs the gynecology service in Vienna. And what he was saying, which was really interesting, is he's actually found that women who had warts when they were young are now presenting with high-grade vulval cancer, precancer. And these are the group also thought to have disease in the anal canal as well. So the epidemiology of what was thought to be a benign cosmetic problem is starting to change, I think, and the books are going to get rewritten. So I'll stop talking for a bit, and I'm happy to be involved with more questions.
I was wondering about irritable bowel disease, and there's a relationship between that and immunosuppression, is there not? So is that perhaps another reason why women with that, besides the frequent bowel movements and diarrhea, would be more at risk?
Yeah, I'd be happy to take that. I did put in the chat, sort of an answer to that, which is along the lines of, if you take immunosuppressive medications, most notably prednisone, you're suppressing your T cell function from the top down. And that suppressed T cell function does not allow the immune system to function in its antigen antibody productivity the way it's normally supposed to work. So on those medications, one, either you get exposed and therefore it evades the system because you've essentially opened the doors, or two, you've already had it, been exposed. And then when you take them chronically, your body's ability to produce antibodies and maintain a sort of normalcy living with the virus gets out of check, and it grows rapidly to the point where you begin to see lesions over time. Both of those are exceedingly plausible, but have not been necessarily shown because it's hard to study outside of the HIV population, that immune system model. But I cannot sit here idly and say that there's no data that supports it other than my anecdotal evidence in clinic, and I see a lot of that. My least favorite drug outside of prednisone is Plaquenil.
So I don't know if Jenny and
Can I?
Okay, go ahead.
I'm going to answer. Karen in the
that's-
chat has said there's plenty of
Thank you.
women who have normal pap smears and get anal cancer. And I have around 250 patients now who fit the bill of the, I call them the general population of patients who wouldn't otherwise be considered at risk. And about 90% of them are actually women. And about 95% of them are not living with HIV or otherwise depressed from an immune standpoint. And the data that I'm hoping at some point to put out would show that about a third of the women will have negative pap smears throughout their entire life, but just get anal canal disease. And it's why I always tell my patients it's not an organ site specific problem. It is an immune dysfunction problem. And where it goes and has lesions that develop are in places that turn over rapidly. Without going into the genetics of the virus, it cannot replicate by itself. It is useless without you. So from an advantage standpoint, the virus will go to places that are the most rapidly turning over in our entire body. I've chose to put the anus up there every 4 days because it's remarkable to say that the least that thing turns over that quickly. The cervix, the vagina, the vulva, the oral pharynx are all right around 6 to 7 days. The other fastest sites in the body. So it goes there, and that's why you get them in these places. You don't see it on the elbow. You don't necessarily see it on the earlobe. Those are cutaneous places that have about a 28-day turnover. So it's not advantageous to live there and grow there. But you can certainly see it in places, in one place and the other. Don't necessarily know why. But I will say we certainly know with great certainty that if you have it in one site, you may as well be screened and surveyed for sites in all the other places that it can potentially be where it can be screened, because it certainly is there. You just can't detect it.
But I agree, Craig, though, that you know, the novo anal cancers that we see in women, you know, you always ask them about their cervical or gynecological history, and often that's negative. So maybe one can assume that they might have cleared the virus at that site, because we know it can be cleared, but it's persisted in the anus for whatever reason.
I'm really cautious about the term clearance because it implies free and never again going to get it. And I think all it does is it goes into a quiescent, non-detectable state. I just don't see how it's possible to generate an antibody to something that you've been living with and not getting rid of it, and then all of a sudden it's gone. I think your body just fights it to a point where it's an undetectable state. At least I counsel my women that, because I want them to know very well that having a risk, for before in one site certainly puts you at risk for others, but for disease recurrence. And it's not likely that I think it's disease re-exposure. It's redevelopment of actively present virus that's just undetectable for some period of time. Latent virus reactivation through significant stressors in life is a real thing. And I think when you disrupt that homeostasis and you suppress your own T cells through stress, which is normal rhinovirus reactivation, you get exposed all the time. You get sick, you're not sleeping, you're not taking good care of yourself, you get sick. It's the same idea, but in a much bigger scale. And it takes years for that delayed effect to truly come into lesions. I don't know, I'm not an epidemiologist, but I just try to apply common sense to this, and that is supported by some of the data that I didn't mention in my talk. It's a much bigger talk, but along those lines.
Yeah, I mean,
So if I just make a comment too, and that is that people always say the virus is there forever and your body's immune system suppresses it. But certainly clinically, what we're starting to see is that if you're virus positive and you have treatment and the virus goes negative, there's very early data that's suggesting that that's prognostically important. So Richard Hillman's seen that out of what he's treating out of Sydney. Stephen Goldstone has found that when you treat people with high-grade precancer, that it seems to be prognostic, that you treat and then the virus disappears, becomes indetectable. And I certainly see that in my patient group as well. So I think that there are signs, and again, it's a huge area that needs more work in so that we have these markers to say people are responding nicely to therapy. Richard, you were going to say something.
No, I think just in terms of our local study that I presented, we kind of went for the group that would give us the most sort of like value for money, as it were, just because we know they've been exposed to high-risk HPV in the past. So, but once again, that's really just the tip of the iceberg. So it was kind of a very selected sample.
There's a comment about having had HPV pre-cervical cancer that became anal cancer. I think you've sort of explained how that could have happened, but does anybody want to comment on that? Said I had 23 years of HPV pre-cervical cancer that turned into anal cancer. So again, it was probably just the proximity of.
So certainly I'd say that having HPV in both places means that your body's not dealing particularly well with the virus. And I would ask, well, what treatment were you offered for precancer in the anal canal, and what screening did you actually have? And I'd be interested to know that, but it's very early days for clinicians. There's a paucity of doctors now who have the skills to know how to actually diagnose this problem. I'm lucky over here in Perth. I have a very good working relationship with the colorectal surgeons, and when they find hemorrhoids, and that's often the place where they find precancer, they then send those patients on to me, and I'm able to, so colorectal surgeons mainly deal with visible, palpable lesions, but at high resolution anoscopy, we're actually dealing with stuff a bit like the gynecologists on the cervix, invisible disease, and we're able to diagnose and treat that. So again, we need a huge number of clinicians skilled to be able to provide this diagnostic and treatment service.
And I think, Jenny, too, you know, like we've been treading very carefully, or at least I have, for the last sort of like almost 20 years, waiting for the ANCOR study to come to fruition, because I always had to couch it in terms of, oh, this is actually experimental. There's no high level evidence to say that screening and treating is going to make a difference in the incidence of anal cancer. We do have a bit of evidence now, which is great. That is not for the main body of people who get anal cancer, but it's a start, and we can use that as ammunition, I guess, to justify our service.
And there's also a dialogue going in the chat box, which is really saying, well, following on from Richard, is that in the anchor study, most of the doctors actually did hyphication. But what's emerging now, and what the next meeting that we're having in Puerto Rico is, where people are saying, well, what is the best treatment now that should be given to prevent these precancerous lesions? So that's an emerging field of evidence, and it's right. I do laser, but lots of other people don't have access to laser, so we don't know what the best treatments is. And the other thing that's very important here is that we're going to have lots of young people doing this examination, but it takes a long time to learn how to become really good at it. And once you're really good at finding the lesions, then you've got to get really good at treating the lesions as well. So there's two learning skills that are actually required. And they've demonstrated that with gastroenterologists doing endoscopy, that you've got to have done a certain number to be good at it. I think it's very much the same with this area of medicine. It's an emerging area of development.
Jenny, can I just ask, make sure I heard you correctly on, I'm sorry, Mary Jo, just to make sure I heard you correctly. We're talking about treating precancerous lesions to prevent cancer. We're not talking about treating HPV positivity to prevent precancerous lesions, right? Because we haven't had any treatment yet that prevents dysplasia from developing. You're just making sure that we're talking about preventing dysplasia from turning into cancer. Is that correct?
High-grade lesions.
That's what I think you were understanding, but I wanted to make sure.
Yeah, high-grade lesions. Yeah.
Yeah, okay. Because we can't prevent the precursor lesions yet. We don't have that yet.
We might be able to, Craig. So in our service, we actually vaccinate all our patients. We vaccinate all the men who have sex with men, and we vaccinate everyone who's coming in for treatment. And that's, again, something that Stephen Goldstone's really encouraged. So vaccination requires 3 injections, and we use Gardasil 9, and it elevates the antibodies 11 times higher than your body can actually do it itself. And one of the things that we talk about with HPV infection is once you're infected, there's a concept that people keep reinfecting themselves. So the vaccine might actually be beneficial when people have microabrasions, that the vaccine stops this, what we call endogenous reinfection. So we think that may be beneficial. So that's been, there is data in women with cervical cancer. There's research out of the Future study that was done by Susan Garland, where women were had HPV and were either given Gardasil 9 or placebo, and the women who were already infected and had placebo, they developed more warts and more precancer than the women who were given Gardasil. So there is evidence that vaccination when people have HPV may be beneficial.
Yeah, the vaccines, I in my mind, again, because I'm surgical in nature, a vaccination is a prevention strategy. Yes, I was only talking about treating something locally for prevention, but absolutely cannot stress that enough, that the vaccinations are critical in our battle to end all things anal cancer, cervical cancer, oropharyngeal cancer, and certainly something I think age independent should be offered. There was a question in the chat about many women being turned away. Men are turned away too for this if they get a little bit older. There's the school of thought that, well, if there's already been an exposure, getting a vaccination isn't necessarily going to make a difference. And I think Jenny just offered some differing evidence there that may not be the case. But it's hard to know the true efficacy of that. Say, for example, in an 80-year-old. Or if it's an 18-year-old, certainly there's a difference in lifespan and the potential exposure. But I tell everyone, it's a shot in the arm 3 times. What does it hurt? You don't want to have the pain from anal cancer. Go get it.
The other thing is, I listen a lot to Stephen Goldstone and his wisdom, but he's always said that when we operate, we actually release free virus. So that's another rationale to stepping in with vaccinating everyone that receives treatment. So that's another thing that we do in our service.
So there's a question about where the, oh, go ahead, sorry.
I think I'm going back to something that Dr. Turner had talked to regarding the lesions that look like warts and high-risk HPV. It's a little bit more nuanced, but Dr. Turner is completely true. lesions that look like warts can only be determined to be warts when they're proven to not have high-risk HPV associated with the anal canal. I truly say you cannot judge this book by its cover. You need to know what HPV is back there to certainly make the association of wart versus not wart. That's my comment I wanted to add there. Sorry, Mary Jo, I keep interrupting you.
No, that's okay.
Please
There's
go.
so many comments and questions. There's no way we're going to get to all of them. One of them was about where does the HPV virus live? And I kind of think you answered that. You know, it's very opportunistic and it lives where it can reproduce is my understanding of it. So
Replicate.
yeah, exactly. Okay. We only have about 4 more minutes. So, and I apologize that we can't speak to every one of these questions, but please understand that these seminars are never long enough. So be in touch with us and let us know what more you want. And also we need to understand that anything we say is not meant as medical advice. You still have to go to your doctor. But anyway, would any of the speakers like to finish up with anything? I think we've given ourselves some really good reasons to speak up when people are shaming us.
Well, the group here clearly understands now that there's no shame in this. It's just in an area that people have stigmatized, but you can't let that keep you from living your life the way you should. And physicians who do offer that sort of opinion of stigmatization are clearly just, they're not as informed as they should be. And that's something that I'm working really feverishly at in my practice to move the needle on that to something that's a lot more outside of the high-risk transmissibility group that's recognized, and just more of the general public. That comes with a lot of data that has to be interpreted very soundly because there's not a lot of buy-in even from my own society membership, but I'm working on that. We're gonna move the needle in our lifetime. It's too slow, but it's better than not moving at all.
Yeah. Dr. Turner?
No, I entirely agree. I think I can only speak for the Australian sort of setting, but to get my surgical colleagues interested in this, it probably needs the government to give it a so-called item number so they can get remunerated for HRA. Up until now, people just do mapping biopsies, which is just totally random and inappropriate. So I think we need to sort of like keep lobbying, really.
And Jenny, Dr. McCloskey?
I'm just lucky I run the sexual health service over here. So we've been able to just siphon a lot of my time away into doing this. And now we've just got recognised last week by my colleagues to say, because of the work we do, anything anal now comes to us. So it's just happened, not by funding or design, but by years of just working on it. Initially publishing that warts had high-grade dysplasia. That changed the way the colorectal surgeons dealt with warts, and then we've evolved, and now we just have this fabulous relationship with our colleagues, and now we're getting everything endoscopy sent to us as well. But yeah, just lucky because we talk and get on well, but huge areas of research required. And I'd just like to credit Richard and Craig for their passion with research.
Me too. We are all very lucky to have all of you. And also we're lucky to have so many participants. And we take the message out as survivors and don't let anybody tell us we don't know, because we do now. We know how we got this and what to do next. So Audra, can you put up the, we want to invite everyone to our podcast. There's a wonderful, the new one, they're not all out yet. We've interviewed a number of people, but the one that Dr. Goldstone did, since his name's come up several times, is really excellent. And that is actually up. So you can find this anywhere. You get it on the website, our website, but any of the places that you listen to podcasts. but this is another way we're trying to get the word out. Okay. All right. Thank you so much. And our next our next seminar that's coming up in December, which isn't all together yet, but we're going to talk about how to talk to your doctor, because sometimes that's a good skill to learn. Okay. Thank you. And we will see you next time.